All right, so the next question was, why was it important for you to include the medical pluralism chapter in the book? There are two reasons I wanted to do that. One is because medical pluralism reflects the reality of people's lives, and to me, that's always really important to be capturing kind of what's true out there, not trying to twist your data into some argument that you already, want to find there. The other reason I wanted to include that is because I think a lot of medical anthropologists tend to shy away from sort of making judgment calls about which I totally get, and it depends what your goal is. So if you're doing comparing ethnomedical systems and trying to understand people's approaches to health and healing alone, then it wouldn't be right to say sort of this way is better than that way. But in the case of something like HIV, where and sort of taking a sort of critical structural violence approach to looking at global health inequalities, you can't really make the argument that traditional healing and biomedicine are of equal value to curing or to treating someone with HIV because you need antiretrovirals to live. And the interesting thing, like I think a way to think about it is, that this disease, which was born out of inequality, both the inequality that gave the Basotho people the land they live on in the first place, and then required to make their living that they worked in the South African mines. So periods of migrant labor where people are already separated from their families, and then this sort of disease that spread through globalization that reflects and sort of kind of reveals a lot of the inequalities in accessing treatments, the care that we have access to if you have HIV in the United States is far superior. So I think to me it was important to make the case that like here's how people experience this and here's the way that they're seeking treatment, but also that there are structural inequalities that mean that one treatment is far superior and you need it to live. And so not shying away from using the sort of unanthropological language of um, you know privileging the biomedicine over other forms. But the next question someone asked in this section that I chose is there a benefit to cultural medicine over Western medicine or vice versa? Or is it just because of a lack of resources or knowledge? And I wanted to answer that question too, because people don't just use um, Sesotho medicine because it's the only thing available. They use it because their understanding of health and well-being in an ecological sense, so when you look at it holistically, can't just be limited to the medicines that you take, but sort of the well-being of the whole human person. And so a lot of those things address cultural factors that might be making them feel unwell, and what does even unwellness mean to them. So I think, drugs, the kind that help you cure illnesses, are great, right? We need them and they do a lot of things for us. Antibiotics keep people alive, like vaccines save a lot of lives. Life expectancy is way longer than it used to be. But you might cure a disease, but not cure your illness, not be healed sort of as a whole human person. And that's what most forms of indigenous medicines, like Sesotho medicine, address that whole human person in their environment, that situated person. And so there's lots of advantages to Sesotho medicine. And for the case of HIV, because biomedicine is needed to live, I would love to see more collaboration between those two groups, because then people could learn like what kind of herbal medicines or traditional medicines might, you know, um, be counterindicated with antiretrovirals or the other things you have to take when you're on HIV meds. But there could be other aspects of traditional healing that could not just treat people's disease, but could give them more sort of holistic well-being. And so I think there's a lot of value in that. The next one it is noted that the majority of healthcare workers are from other African countries. Why aren't many doctors Basotho? Well, there's a really simple reason for this, and it's that there's no med school in Lesotho. So any Basotho doctors that we get, and I've met a few, have to be educated abroad, either in South Africa, that's the number one place they go, but sometimes they go to um, other African countries in West Africa and Southern Africa that have good medical schools. Sometimes they go abroad to the UK or the US. And so that's one big reason. There's been a recent emergence of Basotho nurses because a nursing school opened maybe a decade ago in Lesotho, and so that's been huge. If you are like a pre-med type student or interested in public health or global health, there's some great books that I would love to recommend. One is called A Heart for the Work. It's by Claire Wendland. She's at the University of Wisconsin-Madison. And that one's about a med school in Malawi. And then Julie Livingston's book, Improvising Medicine, is also another great one that if you are interested in international medicine or global health or being a doctor or any of this stuff, that I think that you'd probably find those really interesting. So the next questions are about culture, practices, and perception. So have cultural practices and belief systems contributed to the continuation of the HIV/AIDS epidemic? I personally would argue that I really don't think that they have. When you take a sort of structural critical medical anthropology look at it, because certainly there are, people have networked sexual networks, like a guy who works in South Africa and Uganda talks about these concurrent networks, and the way people have sort of long-term overlapping partnerships is more likely to spread. So people don't actually have more partners or more infidelity than we do, but they have them in a different way. So they're more likely to have like a wife and a girlfriend, for example, or a husband and a boyfriend for a long period of time. And so those people's sexual networks are overlapping for longer and then connecting to that other person's sexual network and that other person's, versus if you have a stable partner and then you have like shorter periods of intercourse with somebody else, then it's going to be less time to move through all those networks concurrently. That's the concurrency theory. But I don't think that's the main driver of it. I think the main driver of it is, lack of education, lack of, and I mean like sex or health education, lack of treatment options, poor infrastructure that makes it difficult for people to access their treatment, for them to have good adherence to their treatment, and the just like poor infrastructure in healthcare and that sort of thing. I think we could potentially have rampant diseases if we didn't have robust healthcare systems, for example. So there are probably some cultural factors that shape how the network is played out, but I think the structural inequalities are really the main driver of the epidemic in Southern Africa. So about disease outbreaks, how does the HIV, well, someone asked, I'm going to combine from some different sections. Someone asked, do you still study HIV? What are you working on now? And then someone else asked, how does HIV epidemic resemble the COVID-19 pandemic? And so those are related, and you'll find out why. So I do still work with this NGO in Lesotho, but in terms of active projects that I'm working on right now, so I started doing a project on elder care in Ghana, which has been briefly interrupted by the COVID-19 pandemic. And then I started doing a project on COVID-19 and healthcare providers. And I was kind of thinking when all the, when everything started happening in March and April, just kind of thinking about like what would be an interesting angle as a medical anthropologist to study. And it really struck me that this like COVID is like the epitome of a kinship disease. Its prevalence in the society is so that it's impacting everyone on like an unprecedented scale, right? Like HIV doesn't impact everyone in the entire world, and this really truly does. And also that it impacts people beyond those who are sick, and it's impacting family networks. People can't get together with their families, and people are worried about bringing it home to their families. And so I decided to study healthcare providers. And so I've done a whole bunch of interviews with doctors and nurses working in ERs and ICUs in the US to kind of understand like how it's a kinship disease for them, and how it's kind of altered their social lives, their social networks. And I picked healthcare providers because they're both witnessing what the disease does to families from the patient care side, and they're experiencing it as someone who's in this at-risk situation every day, going home to their families, from that side as well. So that's what I'm working on now, and have some interesting papers and chapters and stuff I'd be happy to share with you all. So you can ask your professor for that if you'd like. And then The next question is, in chapter 4, there's discussion about AIDS exceptionalism and single target disease. What other major diseases are being overlooked in Lesotho? So I think the biggest issue is that in a lot of the global south, and if you read the Livingston book I recommended to you, you'll learn about this, but people don't really pay that much attention to chronic diseases in the global south. So most of the funding goes to these vertical interventions to target, you know, polio, to target tuberculosis, to target malaria, to target HIV, and malnutrition too. But people aren't, you know, people sort of think like we've got to put out these fires before we can, build an oncology ward and give people treatment for cancer. There's only like outside of South Africa, there's only a couple countries in Southern Africa that even have oncology wards at all. So if you are from Lesotho and you get cancer, you cannot get chemotherapy or radiation in Lesotho. You have to go out of the country, and that's true for a lot of Southern African countries. And things like diabetes, and other chronic diseases. COPD is a lung disease that lots of people get in the global south, especially if they cook inside their homes with fire. So those are the things that I think would be really important to look into. But the other thing, and I think there was a question about it somewhere here. One of the questions is, how do you suggest global health interventions change to avoid narrowly targeted work against AIDS, which can inhibit the general growth of health infrastructure and work towards other health issues? Well, a lot of that has to do with like when HIV was in crisis in like 2004 to 2000, I mean, we're probably still in it, but say 2010, 12, you couldn't ignore it. You had to really put a lot of resources into it. But if you could build resources in a way that's both dealing with the vertical problem, but also strengthening health systems, so the horizontal approach. So it's what's called a diagonal approach. It's like dealing with the problem at hand that you have, like you can't just be like Ebola is happening in West Africa, and you in 2014 or 2015, you can't say, well, we're gonna build a primary healthcare system so that hopefully that will help with Ebola. No, because Ebola needs to be dealt with right now, right? So sometimes you need to do that, but to design those interventions in a way that also strengthens health systems, trains people, puts things in place that are going to help people get primary care and deal with some of these longer term chronic diseases or non-communicable diseases. I think that would be a really effective way. And lots of Paul Farmer and lots of medical anthropologists have written a lot about the need for diagonal interventions that both deal with the sort of infectious disease or really acute problems that are happening then, but also at the same time build health infrastructure and human capital that will help the long-term health of a population. And then the last question you had, and I've got 2 more minutes here on my recording, is in the preface, you talk about how to best represent suffering, citing the danger of the single story, and use literary elements to avoid this type of representation in your book. And then how do you suggest international organizations or NGOs try to avoid this sort of like savior-like type of thinking? I mean, I think the most important thing is that you collaborate and get the input of the people that you're working with, right? They should be driving it, and then you should be supporting it and providing whatever expertise you have. You need to listen in order to do that. I think we need to be changing the way students prepare to go abroad, either for study abroad or to do like volunteer work abroad, rather than thinking of ourselves as like, if you come in and hold babies at an orphanage for a summer and then leave, that doesn't really help in a systemic way, right? So thinking differently about what kinds of support is actually beneficial and reframing it. And even if the people do go and hold babies for a summer, how to understand what they did and how to represent it, I think is really important. And then also don't over innovate. Don't try to change everything to be like what you think the ideal would be. That's been a problem with sort of international aid in that sense. And then also don't differentiate. So if you have this big organization that kind of says like, we're going to help AIDS in Africa, and then you treat all AIDS in Africa the same without attending to local differences, then you're not going to come up with a very good solution. So my video is going to cut me off in about 20 seconds. So that's all I'm going to talk to you about today, which is good because I can keep going on. And thank you so much again for your awesome questions.